Hi, my name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas. And I'm here with Dr. Michael Bloch, who's a professor of internal medicine at the University of Nevada in Reno. And he runs, he's also a lipidologist, very interested in that. And that's what I'd like to ask you about. The world of lipidology is excited right now with the advent of PCSK9s, and I know you gave a talk on that. Why don't you tell us what they are from the audience and how valuable they are?
Sure. So PCSK9, one of the cool things about it is it's really helped us understand a little bit more about lipid physiology and the physiology of LDL cholesterol or bad cholesterol.
Right.
And so PCSK9 is very involved in the targeting the LDL receptor for destruction. So when we block PCSK9, we see more LDL receptors around.
Was that a natural occurring substance, PCSK9?
PCSK9 is a naturally occurring substance. And one of the interesting things is there's some genetic polymorphisms, some differences in genetics out there among people that have showed us how this works. People who have lots of PCSK9 activity, right? They have lots of it, tend to have a lot of heart disease, high LDL cholesterol and high heart disease. People who have really low PCSK9 tend to have low cholesterol, low risk of heart disease. So kind of made us think this is a good therapeutic target. So these PCSK9 drugs are antibodies that bind to that molecule. So they inactivate PCSK9, so we see more LDL receptors, lower LDL cholesterol. And in most studies, they decrease LDL cholesterol by about 60%.
Any outcome studies with the drugs? And I guess there are two of them, right?
Yeah, there's two drugs that are currently approved. There's others in the pipeline. And we don't yet have good quality outcome studies yet. We did show a little bit of provocative data that suggests that in the studies we so far have, there does seem to be a trend to fewer cardiovascular events, but it's still pretty early data at this point. But they do very significantly lower LDL-C, which is a real powerful addition to our armamentarium.
Interesting you mentioned about PCSK9 high or low. Like I would think people with familial hypercholesterolemia may have a high PCSK9 level, and people that have high LDL may have.
So there is a subgroup of people with FH, familial hypercholesterolemia, where it's not a genetic problem with the LDL receptor, it actually is PCSK9. And one of the things we've recognized is most of our strategies that we've taken to lower LDL-C, things like statins, even cholesterol absorption inhibitors, when you give them, they actually upregulate PCSK9. So you're sort of it's putting the brakes on a little bit of that, what you're trying to do. And so using PCSK9 inhibitors in combination with those drugs, at least theoretically, makes a lot of sense.
So, right now, I mean, FH we've treated with statins. So you're saying I may be doing some of my patients a disfavor by giving them a statin?
No, statin is definitely the first choice in those patients. It's not that we're doing a disservice, it's that statins don't quite get us as much efficacy as we hope in those patients. So many of those patients need additional LDL-C lowering, and that is one group of people where these drugs are approved, people with FH who don't have adequate control of their LDL. So you leave them on the statin, and then add a PCSK9 inhibitor on.
Why don't you talk, because there are FDA indications for it. You want to share what those are?
Sure. So the FDA indications, they spend a lot of time working with the companies who make them. And essentially both drugs, very similar indications, indicated for patients with established atherosclerotic cardiovascular disease or FH who are on
statin.
They're on a statin at the highest I'm trying to remember the terminology they use, the highest tolerated dose. So in many patients, that's going to be a high dose of a statin. Some patients, though, don't tolerate statins. It may be a much lower dose or zero statin. So patients with FH or established cardiovascular disease who have inadequate control of LDL cholesterol who are already on a maximum tolerated statin dose. And that's where we're using them. And it's very interesting. It's just in the last few years, we've now have all of these other drugs available to treat LDL cholesterol. And many of them, like PCSK9 inhibitors, are super powerful and really trying to figure out, like you say with the indication, trying to figure out how we use this powerful technology, you know, it's expensive and in what setting should we be using it, I think is really kind of the next step. We know they work, we know they lower LDL, you know, when should we be using this powerful tool?
Talk about the downside, you know, with statins, you know, when they said, 1 to 3% are going to have, muscle symptoms, and one it's much higher than that. How about the downside of PCSK9s?
Yeah, so that's one of the nice things about these drugs is the side effect profile has been, pretty clean.
Right.
Don't really cause muscle symptoms more than placebo.
Right.
They don't seem to cause neurocognitive effects more than placebo. They sometimes you can get a little bit of a sort of viral illness feeling with them a little bit, but generally they've been really well tolerated in the clinical studies we have to date.
Right.
Again, so it's thousands of patients, but it's not tens of thousands of patients. And importantly, we don't have long-term data.
Right.
One of the real questions that is going to need to be answered is, if in some cases you're lowering LDL cholesterol with these drugs to below 25, below 40. In these short-term studies, that seems to be fine. No major side effects to it. But we're going to need to see if down the road, how do patients do if you keep their LDL cholesterol levels down?
So when you say short-term, how long did they last?
We have studies up to 52 weeks.
Okay, so it's a year long.
Year long.
Okay.
And there's outcome studies that are ongoing now, looking at their effect on cardiovascular outcomes. And one of the nice things about that is not only will we have that cardiovascular outcomes data, we'll also see safety data for 3 or 4 years. And like I say, many of these patients are going to have LDL cholesterols of 20 or so.
Right. Well, we talk, we think, because we're used to seeing 170, what have you, 200. I mean, some people normally have very low cholesterols that do fine. But I don't know, what's the lowest we have running around there normal?
If we were to fill this chair with different people, they'd give you a different number, and they'd have a different level of comfort with it. For me, I think I'm a little more conservative than some of my colleagues. I think our data, down to, in the 40s, like having LDL-Cs in the 40s, we have pretty good data that seems to reduce events and seems to be well tolerated for the fairly long term. Below that, I think the jury is still out. You get some of us, because of a lack of data, who think it's fine, some don't think it's fine.
Sure.
It's pretty unusual to see people with that low of an LDL cholesterol who aren't on a statin, but there are some genetic abnormalities that lead to very, very low cholesterol, and those patients do seem to do okay.
Right. Let's go back to indications and who tolerates it, and I'm thinking of a couple specific populations, because our FH patients, although we may have, like I happen to have a mother and 2 daughters, and the daughters, are teenagers.
Yes.
Yeah, there are some, statins can be given that, but what about PCSK9? Can we give them the pediatric population?
So they're indicated in adults, and there have been some studies done in homozygote FH, that's people with 2 bad copies who have LDL cholesterols in the 400 or 500s that have been done in younger individuals. But so far, what we have is indication for adults in heterozygous in those patients.
Okay, so and that's probably over 18 or 20?
Over 18.
Over 18.
That's
okay. All right. What about, we're in the corner with pregnant women, and I think of, if a mother has FH, probably heterozygous FH, was extremely high, it's going to expose those babies to all that cholesterol. Yeah. So do we have, I know we can't use statins. What about PCSK9?
Yeah, there shouldn't be used in pregnant women because they haven't been studied in pregnant women. It's an interesting concept. I wonder if those studies will ever be done. As it is, and we always, the one therapy that we know is safe and effective in women who really need to have their LDL cholesterol controlled during pregnancy is apheresis. But not everybody has apheresis available to them. It would be nice to have a pharmacologic option.
Sure, and that's probably for, really super high.
Yes, most women can tolerate, most heterozygotes, can, both them and their babies, their fetuses can tolerate being untreated for that 9 months.
Okay. One of the challenging questions about PCSK9 is the cost. And I don't know if you start to try to prescribe them yet and you try to talk to the insurance company and you don't get the results you like. Any suggestions or thoughts about that?
Yeah, we've seen across the board. We have prescribed quite a bit. We had a whole list of folks who've been waiting for approval of these drugs. We run a pretty large family lipid clinic. And it's been it's been very unpredictable, I would say. That's how our response has been so far. It's only been a few weeks. Some have gone through no problem. Others we've had to ask for prior auth. Some of those prior auths have been approved, some not approved. And it's really been across the board. I would say the advice I would give, there are both companies that currently have approved drugs have a support team that is easy to access. You can access them on the web. We actually do it by fax usually. There's forms that you can fax in, and they will help assist you in jumping through the hoops that you need in order to try to get that third-party payer to pay for it. They also will, both companies say they're committed to providing drug during that process. So they give a free drug. And they also do the injection training and things like that. So there's a support team that's available. And our, once again, limited experience so far, those support teams have been extremely helpful.
All right. Then, of course, the question, I don't know if it's fair to ask you, but you got 2 drugs. I don't think there are any head-to-head studies. But is there any difference in one versus the other?
No, we have 2 drugs, and there, as you mentioned, there are really no head-to-head studies. More alike than they are different. And if you try to compare the studies in terms of efficacy and safety, look about the same. A couple of differences just in terms of dosing and things like that, but they're more alike than they are different. Yeah,
because you can give one of them just once a month. You both of them every 2 weeks. Is that true with dosing?
Yeah, the dosing, yes. And they have different, the way you can give it once a month varies depending on the drug. But I'd say in general, they're more alike than they are different.
Okay. Well, very good, Michael. This is very, very, very helpful. Thank you for talking to me.
Oh, pleasure.
Yes, sir.